Hello, I'm Dr. Renu Hausen. I'm a radiation oncologist with the Northwell Health Cancer Institute. I will be giving a presentation on skin cancer, what causes it, the different types of skin cancer, signs and symptoms, proper medical evaluation, treatment options, and results of treatment, with a special emphasis on non-surgical radiation treatment. Skin cancer is the most common form of malignancy in the United States. There's more skin cancer in the U.S. population than all other cancers combined. 1 in 5 people in their lifetime will develop skin cancer, and approximately 9,500 Americans are diagnosed every day with skin cancer. The vast majority of these are located in the head and neck region, the nose, the ear, the eyelid, the scalp. And approximately 50% of patients who have a skin cancer will develop a second primary skin cancer within 5 years. So the most common cause of skin cancer is radiation exposure, especially ultraviolet light, and that incidence is increasing with tanning bed use. Fair skin types are more prone to developing skin cancer. Those would be Fitzpatrick skin types 1 through 3. Patients who are older are more likely to have skin cancer. Skin cancer is relatively uncommon in those younger than the age of 45. Family history of skin cancer might predispose one to developing skin cancer. Those who are immunosuppressed, who have a weakened immune system, such as patients who have undergone organ transplants, have HIV or lymphoma or leukemia, are more prone to developing skin cancer. Areas of chronic inflammation may lead to skin cancer. Patients who have large numbers of moles may be more prone to developing it. And certain chemical exposures, particularly arsenic, have been correlated with skin cancer development. The anatomy of the skin is composed of 3 main layers. The outermost layer is the epidermis. Underneath that is the dermis, and beneath that is the subcutaneous layer. Within the subcutaneous layer, we have blood vessels and nerves that will then penetrate into the dermal layer as well. And if you look on the right side of the screen, you'll see a photomicrograph of the skin, and you can see the outermost layer here. In the epidermis is the stratum corneum, underneath is the stratum spinosum, and at the bottom of that is the stratum basale. And underneath, of course, the epidermal layer is the dermis. The signs and symptoms of skin malignancies include a new lesion that's growing or persistent, any areas of irritation or redness. There may be itching associated with the lesion, scabbing or scaling. Skin cancer lesions often have crusting, oozing, or bleeding, and there may be tenderness or pain. So a full-body skin examination should be done to evaluate for any suspicious lesions. This is a very methodical approach, and you can see there is a schematic of that here, and the dermatologist will examine all surfaces of the skin to identify any suspicious lesions. If a lesion or multiple lesions are identified, then a biopsy should be performed. This will be either a punch biopsy or a shave biopsy. The punch biopsy is done with a tool that looks a little bit like a hole puncher, and a very small cylinder of tissue is removed. With a shave biopsy, a surgical razor blade is used, and the superficial layer of the lesion is removed. The specimen is then sent for histopathologic examination. It's sent specifically to a dermatopathologist who will look at the lesion, the specimen under the microscope, and determine if there is any malignancy there. Precancerous lesion may be identified. These are known as actinic keratoses. And the treatment for these is often just cryotherapy, which is liquid nitrogen, or topical creams such as Effudex cream or Aldera cream. You can see that this is a patient who had multiple actinic keratoses on her face. She was treated with Efudex cream, and it became quite red and resolved subsequently with a very good result. Another option might be photodynamic therapy, which is a solution of Levulan, which is painted onto the skin and then activated with a blue light. Now, for malignant invasive skin cancers, there are two general categories. There are melanomas and there are non-melanomas. Non-melanomas are basal cell cancers, squamous cell cancers, and various other skin cancers that are much less common. And here we can see the types of skin cancer, the most common types of skin cancer: squamous cell cancers, basal cell cancers, and melanomas. So melanomas represent 4% of all skin cancers. They arise from melanocytes within the epidermis. They often will present as a mole, but not always. Early detection and proper treatment can yield very high cure rates, but unfortunately the majority of melanomas are not diagnosed at an early stage. Once the melanoma has spread to lymph nodes or to other parts of the body, unfortunately the prognosis remains poor. The warning signs of melanoma are, we follow the ABCDE rule. Asymmetry. If you draw a line down the center of the lesion, you will notice that the left side does not look like the right side. There may be irregularity to the border. It may appear uneven, scalloped, or notched. There may be variations in color, multiple different colors present within the lesion, including tan or black, or there may be red or blue mixed in, or sometimes white. The diameter would, if there's a lesion that's larger than the head of a pencil eraser, which is approximately 6 millimeters or 1/4 of an inch, or a lesion that's evolving over time, it's changing. And here we can see some examples of normal skin on the top, normal lesions on the top, and melanoma lesions in the bottom row. And in the first column we can see an example of asymmetry. We can see border irregularity. We can see multiple colors in that third lesion. The diameter of the lesion is larger. And then in the last example there, we can see that some of these lesions are changing. They're evolving over time. And here's some more examples of suspicious lesions consistent with melanoma. So deaths from skin cancer are not very common unless the diagnosis is melanoma. The majority of deaths from skin cancer are attributed to melanoma at approximately 75%. Squamous cell cancers may account for approximately 15 to 20% of deaths, and the other skin cancer types represent the other deaths from skin cancer. Now, basal cell skin cancer is the most common of all the skin cancers. It's also the most common non-melanoma skin cancer, represents approximately 80% of skin malignancies that are diagnosed. Basal cell skin cancers arise from the cells in the bottommost layer of the epidermis, the basal layer, or the stratum basale. Basal cell skin cancers occur most frequently on sun-exposed areas of the body, so primarily the face, the ears, the scalp, the neck, and the upper trunk. They tend to grow very slowly, and they rarely spread. They rarely metastasize. And these are some examples of typical basal cell cancers. This one in the upper left is a basal cell cancer near the patient's left eyebrow, temple region. Here's a typical basal cell cancer on the nose. Here's one on the lower back of the ear, the outer edge. And here is a basal cell cancer below the lower lip. Squamous cell cancers are the second most common skin malignancy, and they represent approximately 20% of non-melanoma skin cancers. They arise from squamous cells in the upper layer of the epidermis. And these lesions often appear rough or scaly, red, or crusted over. This schematic shows that there may be some heaped up edges and a bit of a crater in the center. Squamous cell carcinomas also tend to occur in sun-exposed areas of the body, but they can actually develop anywhere. And squamous cell cancers do have the ability to metastasize. They can spread to other parts of the body. And here are some examples of squamous cell cancers. This one is a squamous cell cancer on the cheek. Here is one that is on the ear. And this squamous cell cancer here is on the back of the hand. And this squamous cell cancer is on the leg, on the shin, the lower leg. So early basal cell cancers and squamous cell cancers can be treated with liquid nitrogen, cryotherapy, or they can be treated with topical chemotherapy creams such as Efudex or imiquimod. And we can see here's a patient who's had Efudex cream over her entire face, and it's turned bright red, but it will resolve within a few days and look very good. The dermatologist may do a curettage and electrodesiccation. That's essentially where they cauterize the lesion. Tumors that have fairly well-defined borders can undergo surgical excision, or tumors may undergo a specialized surgical procedure called Mohs surgery. And depending on the size of the defect, this may or may not require plastic surgery reconstruction. And then radiation therapy is another well-recognized treatment modality for basal cell and squamous cell skin cancers. So Mohs surgery is a specialized technique where the Mohs surgeon identifies the lesion and removes the visible portion of it on the surface of the skin and examines it immediately under a microscope. And if tumor cells are identified at the base of the excision specimen that was removed, then that indicates that there are still cancer cells remaining in the skin. So another layer of skin in the region of the lesion is removed, examined under the microscope. If tumor cells are found at the base of that excision specimen, further excision is done, and the process is repeated until finally, when the skin layer is removed and there are no skin cancer cells at the base of that specimen, we can be confident that the skin lesion has been removed in its entirety. So Mohs surgeries can take several hours, and they may require multiple stages, depending upon the depth of the lesion. And depending upon the defect that's left, if it's a small defect, it may be closed primarily, or if it's a larger defect or a deeper defect, the patient may require reconstruction to repair it. So skin cancers can be stratified in terms of risk based on their location on the body. And we have 3 risk categories: low, moderate, and high. So low-risk areas would include the trunk and the extremities. So skin cancers that occur in low-risk areas have a very, very high chance of being cured with treatment with very low risk of recurrence. High-risk lesions occur in particularly regions of the face where there are embryonic fusion planes. And you can see here on the schematic that the areas that are shaded in red represent the high-risk areas. The embryonic fusion planes are the regions of the face that developed while the embryo was in utero and where the planes came together to form the features of the face. And lesions, skin cancers that develop in these areas can be much deeper than what they appear on the surface, which makes them at a higher risk for recurrence despite treatment. And then moderate risk tumors are those that are not on the trunk or extremities or are not in these high-risk regions of the face and scalp. So how do we manage skin cancers? Surgery is often the most effective and efficient treatment. However, there are considerations of function and cosmetic outcome and patient preference that may lead a patient to choose radiotherapy or the treating physician to recommend radiation treatment. So ideally, there would be shared decision-making between the patient and the provider regarding the treatment. Radiotherapy offers cosmetic benefits that are quite significant, and these are especially true for tumors that are around the lips, the nose, the ears, and the eyelids. Now, what are some factors that may favor radiation treatment over surgery? So in patients who are older, there's going to be less risk of any late side effects with radiation treatment versus younger patients. Patients who are debilitated or who are not good candidates for surgery are almost always good candidates for radiation treatment. Tumors that are larger than 5 millimeters that are occurring anywhere in the central face region, especially the eyelids, the nose, or the lips. Larger tumors of the ear or forehead or scalp do especially well with radiation treatment. And if the patient prefers a non-surgical approach, such as radiation, rather than surgery. So the factors that may favor treatment with surgery rather than radiotherapy, if a patient has had prior radiation treatment to that involved area, it's often not possible to give more radiotherapy. There are certain genetic conditions that dispose patients to skin cancer development, and we would want to avoid radiotherapy in these patients. There are certain conditions also that increase the risk of side effects from radiation treatment. These are primarily the connective tissue diseases like scleroderma. Tumors of the trunk and extremities are often treated, quite efficiently and effectively with surgery. And larger multifocal or deep tumors may actually have a better cure rate with surgery, but that would be at the expense of possibly some functional impairment or less than optimal cosmesis. And patients who are younger often prefer surgery over radiation. So comparing the outcomes of the various treatment modalities, we can see that they're actually quite similar. For low-risk tumors, we have disease control in better than 90-95% of patients, whether it's a surgical excision or the Mohs specialized surgery or radiation treatment. With the high-risk tumors, the best control rates seem to be with Mohs surgery, which is just a little bit better than with radiation therapy, and which is better than it is with just simple surgical excision. So if we look at some published results of the treatments for skin cancer and how they compare, we see that there's evidence that shows that surgery may offer better outcomes and local control as compared to radiation treatment, but these studies are a little bit older. They were published more than 20 years ago, and there are nuances in patient selection that may favor radiation in many of these cases. There was a more recent analysis of over 300 patients published in 2017 that compared electronic brachytherapy, a type of radiation treatment, versus Mohs surgery that showed local control rates at 3 years that were excellent in the 99 to 100% range for both groups of patients. And there was another analysis of over 40 trials. It's a meta-analysis, and again, it also showed that recurrence rates were very low for both surgery and for radiation treatment. Locally advanced tumors, however, are those that are involving cartilage, bone, muscle, or nerve. These do, unfortunately, have lower cure rates regardless of the type of treatment that's used, and often these patients need both surgery and radiation treatment. So how does radiation treatment work? So high-energy X-rays are generated. They interact with water in the cells. Remember that our skin cells are at least 85–90% water, so water is abundant in the cells. The X-rays interact with the water. They lyse the water molecule into hydrogen and oxygen. Free radicals are generated. These free radicals then bind to the DNA double helix, and they damage the DNA. And when that DNA is damaged, the cell is unable to reproduce. So at the time of mitosis, the cell is unable to reproduce. It suffers mitotic catastrophe, and then this leads to cell death. So it is a reproductive cell death. Cancer cells do not have repair mechanisms, whereas normal cells have abundant mechanisms to repair any DNA damage caused by these free radicals. And so normal cells are generally spared the effects of radiation, whereas cancer cells are not. So the gray is the unit of radiotherapy dose. 1 gray is 100 centigrade, and the dose from 1 centigrade is roughly equivalent to the dose you would receive from undergoing 1 CT scan. So the radiation dose prescription depends on the goal of treatment, if we're treating to cure versus palliation or just improvement of symptoms, how much disease there is, if there's an actual gross lesion to be treated versus in a postoperative setting where we're treating microscopic tumor cells, and the radiation sensitivity of the particular type of skin cancer. Melanomas require, generally speaking, higher doses than squamous cells or basal cells, and the radiation sensitivity of the surrounding normal tissue. So radiation is delivered in a series of daily fractions, and this fractionation allows for DNA repair in the normal tissue. So some common prescriptions of radiotherapy might include approximately 5,000 to 6,000 centigrade, 50 to 60 gray, delivered in 20–25 fractions, or 40 gray in 8 fractions. Patients typically are treated 5 days per week, or if they're undergoing skin brachytherapy, they may be treated just 2 days per week. Each visit is only 15 minutes, so it's very quick. And radiation may be delivered with a superficial or orthovoltage unit, which will deliver lower energy X-rays that are still quite effective, or radiation may be delivered with a linear accelerator, where electrons or higher energy X-rays can be generated to treat the patient. And brachytherapy is another method for delivering radiation treatment, and this involves a radioactive source that delivers gamma rays directly to the lesion. You can see this is a brachytherapy implant for a skin cancer in the lower lip. Here's a brachytherapy surface mold for skin cancer on the surface of the foot, and here are some brachytherapy applicators, surface applicators that can be used. We'll get another look at them here. These are the Valencia applicators or the Leipzig applicators, and these are very useful for small superficial tumors that are on more of a flat surface. Or we may use a surface mold when we have a more irregular surface or a curved contour. So this is a patient who has a squamous cell skin cancer on his finger, and a surface mold is created and wraps around this, and then in the third picture you can see the ultimate outcome. The skin cancer has been eradicated with a very good result. Here's some more examples of treatment with brachytherapy. This patient had a skin cancer on his nose, and that's before treatment. And then during treatment, you can see that the area becomes red, and at the last treatment, it's quite red, but the lesion is definitely resolving. And then about 2 months after treatment, you can see that the skin color has returned to normal, and the skin cancer is gone. This is a squamous cell cancer on a patient's ear before treatment, and then after radiation treatment, the lesion has resolved. And this is a patient with skin cancer on their nose, and this patient was treated with brachytherapy, and this is the result 3 months after radiation treatment was completed. Excellent cosmetic outcome, and the lesion is resolved. And this patient had 2 lesions, 2 skin cancers, one on the top of the nose near the tip, and one on the side of the nose. We call that the nasal ala. And patient was treated with brachytherapy, and it's 8 treatment sessions. At fraction number 7, treatment number 7, the area is turning quite red because of the radiation. 1 month after radiation, much of the redness is faded. The lesion is, both lesions are contracting, and then 6 months after radiation treatment was completed, you can see that the lesions are completely resolved, and there is an excellent cosmetic outcome. And this is a patient with a squamous cell cancer below the eyelid, and before treatment. This is at 1 month after treatment, and 2.5 months later, and then finally 1.5 years later, and you can see that the lesion is completely resolved with excellent cosmesis. Another patient with skin cancer on the tip of his nose before treatment and after radiation treatment's been completed. And this patient had 2 lesions on the back of the ear, and this is before treatment, and you can see here after treatment, very good result. This is a patient with a larger squamous cell cancer on his right temple, and you can see this is pretty typical with these heaped up edges and this sort of central crater-like area. This is what happens when squamous cell cancers continue to grow, and he was treated with radiation therapy, and you can see after the lesion is gone. It's resolved, but there is a little bit of a depression there because of the skin tissues and subcutaneous tissues that were destroyed by the tumor. And this is a patient with a basal cell cancer of the upper lip, and she was successfully treated with radiation treatment as well. So the main side effect of radiotherapy will be redness of the skin in the region that's being treated. There may be some peeling as well, so what we call dry desquamation. And some patients, a few patients may develop moist desquamation, and this will tend to occur in lesions that are a little bit larger that may need to be treated at higher dose levels. But all of these side effects resolve, some promptly, some take a few weeks. And how we manage these side effects include avoiding friction or trauma to the area. We want to avoid any scrubbing. We want to avoid any harsh cleansers. or cosmetics, especially if they contain alcohol. When redness or the dry peeling develops, we want to use emollient lotions and creams, very gentle cleansing agents, and just patting the skin dry. Or if there's a lot of itching associated with the lesion, we may recommend some cortisone cream, topical corticosteroids. For the patients that develop the moist desquamation, we may prescribe Silvadene cream, which will promote the skin healing. And for lesions that may be at risk for infection or becoming infected, then either topical or oral antibiotics. Some patients may develop some hyperpigmentation, which is some skin darkening or tanning of the skin. This is due to radiation stimulating the melanocytes in the basal layer of the skin. That usually resolves within just a couple of months, but in a few patients it may become a little bit more permanent. Some patients may also experience some temporary hair loss, but for most patients the hair will grow back in about 3 to 5 months. And this is a summary slide that shows that the long-term cosmetic outcomes with radiation treatment and tumor control are usually very good to excellent. This is patient's scalp. This is a patient with skin cancer on the ear. This patient with skin cancer on their nose, and it's a patient with the skin cancer on their lower leg. So our specialty society, the American Society for Radiation Oncology, we call it ASTRO for short, issued a clinical practice guideline recently, which states that radiotherapy is an effective therapy for durable local control of basal cell skin cancers and squamous cell skin cancers that's characterized by an appealing combination of therapeutic efficacy and functional and cosmetic preservation. These features make definitive radiotherapy an attractive alternative to surgery. So I will conclude with some words of wisdom from Benjamin Franklin. An ounce of prevention is worth a pound in cure. And these are the measures that we recommend to diminish our risk for developing skin cancer. Protective clothing, hats, and sunglasses, like these adorable little children here are doing. They've got the right idea with their hats and their full-body sunsuits. Utilizing a broad-spectrum sunscreen that covers both UVA and UVB light. Reapplying that sunscreen every 2 hours or after swimming or physical exertion where there's a lot of perspiring. Avoiding sun exposure, if possible, between the hours of 10 in the morning and 4 in the afternoon, which unfortunately is the best part of the day. If you are out in the sun, you want to try and stay as much as possible in the shade. Thank you very much for listening. I'm Dr. Renu Hausen, radiation oncologist with the Northwell Health Cancer Institute.